Hi, Apollo Cancer Centers from ACC. Today, we are here with our experts to discuss about lung cancer. So, welcome to this podcast. I am Dr. Poonam Maurya, consultant medical oncologist at Apollo Hospitals, and we have a lot of experts with us today. We will discuss about lung cancer, what are the various risk factors and what are the myths and what are the facts about lung cancer. So, here we have with us Dr. Vishwanath, who is the senior consultant medical oncologist. Hi, Dr. Vishwanath. And we have Dr. Anil who is our senior consultant surgical oncology. Hello, Dr. Anil. And we have Dr. Vinay sir. He is a senior consultant radiation oncologist. Welcome,
Hello.
sir.
Hello.
So we welcome all the experts over here. And today, let's burst some myths and let us know the facts about lung cancer. Cancer is becoming very common. And rather than getting overwhelmed by this disease, let's get more empowered by knowing the facts and bursting the myths today. So my first question to you, Dr. Vishwanath, why do you think lung cancer is becoming common?
Thank you, Dr. Poonam. As we know, lung cancer is one of the most common cancers in India, not only in India, globally as well. And previously, maybe 20-30 years back, it was probably attributed only to smoking. And now we see that in men as well as in women, we are seeing lung cancer quite commonly. And probably there are quite a few other factors apart from smoking, which could include our environmental pollutants, which significantly contribute to this causation. And apart from passive smoking, what we call a second-hand smoke and third-hand smoke.
Yeah, correct. Rightly told. People think that only if you smoke you'll get. It's not so. If you have got a house in a basement, a lot of radon exposure will be there. And people already know the effect of Hiroshima Nagasaki bombing. Those people are affected more lung cancer. And occupationally also, as Dr. Vishwanath is telling, this is one of the important non-smoking causes like silicosis, asbestosis. These also contribute apart from the pollution of whatever urbanization we are seeing, lot of construction activity. All those contribute apart from the routine smoking.
Yes.
For lung cancer.
Yes, so nicely told. The smoking and the non-smoking causes. So we all think that smoking is the only cause, but no, there are several causes of lung cancer. So now these are the various risk factors. We came to know not only the smoking and the environmental pollution, whereas the radiation exposure, there are so many other causes of lung cancer. Now, how to diagnose lung cancer? Like, how can you tell, okay, I'm going to get lung cancer, or do I have lung cancer, doctor? So, what are the signs and symptoms that you would generally expect? Dr. Anil, you can have any.
First, let us be aware of the typical lung cancer patient. He is going to be an elderly gentleman who has been a smoker for a long period of time. And the typical symptom is that he has cough, which lasts beyond expectation of a reasonable time, say 2 weeks or 3 weeks, especially if it is associated with blood. So if it is cough with blood, then the chances of it being lung cancer are much higher. This is the typical patient, but we may not get the typical patient every time. It may not always be an old person. We are seeing more and more lung cancer in younger patients. Smoking history may not be there. In about 10 to 20% of the patients, there is no smoking history. Cough, again, can be due to many other causes. It can be a smoker's cough or what we call because of COPD and other things. Many times when smokers do get cough, it is not because of lung cancer, but when the symptoms last beyond a particular period of time, that is when we suspect. Blood in cough should be a symptom which should raise the alarm bells. And we as clinicians would be more inclined to investigate further. Also, we must remember that apart from these, we might get a totally asymptomatic patient who has just gone for a health check and who has been diagnosed. Especially during COVID, we saw an increase in the number of lung cancer detected because the number of chest x-rays and CT scans which were done went up. And on the other end spectrum, patients may come with a very advanced We have patients who came with back pain, and on evaluation we found that they have a lung cancer. Sometimes they come with enlarged neck nodes. And then when we evaluate, we find that there is this thing. There is hoarseness of voice, and we have evaluated and found lung cancer. So all these symptoms can be because of lung cancer. It is not for the patients to decide. They should be aware of the symptoms, and if any of these, they should go to a person who is capable of diagnosing lung cancer.
Yeah. Thank you, Dr. Anil. So, the signs and symptoms, as we came to know now, are very vague. They are not very specific to cancer, and that's the reason many of the times the detection is quite late. So, it's best to have annual screening, because when you don't have any problem, that's the best time to get detected, because early detection is the best prevention. So now after we know these signs and symptoms, so suppose if we have a typical patient, then if we are suspecting lung cancer, so how do we go about, what do we do further to actually confirm the diagnosis of lung cancer, and what are the newer things which have come in the diagnosis of lung cancer which has changed and revolutionized the treatment of lung cancer? Dr. Vishwanath.
Yeah. So generally, like, just to add to what Dr. Anil Kamath said, patients are not usually diagnosed by an oncologist. They generally go with these kind of symptoms, which to a physician or a general practitioner, and that's where we get most of our patients from. So a typical initial investigation is an X-ray, and the chest X-ray may reveal a lung mass, which could be either in the peripheral area or it could be in the central area. And then subsequently, when we see that kind of a mass, we go ahead and order some additional investigations like a CT scan. So CT scan will give the exact nature of the mass and where it is located. And of course, the gold standard of diagnosis is always a tissue diagnosis. So we need a biopsy. So any mass which is located in the periphery, we go ahead by what is called as a CT guided biopsy, which is a simple procedure done by interventional radiologists. And if the mass is central, we have got excellent interventional pulmonologists, even in our center at Apollo Jayanagar and Banagata Road, and who are able to do this procedure called endobronchial ultrasound, and they get a biopsy which is called E-bus guided biopsy, and which can yield very good results, and we get there's 95% sensitivity in getting these kind of getting the diagnosis. And once we make a diagnosis, of course, the high-end investigation, which has become like a one-stop investigation called PET-CT, which is whole body scan, and which will tell us where there is disease and how active the disease is, and of course, where all it is spread. So this is the way we approach a patient who is suspected to have a lung cancer.
So so after the staging of the disease and getting the biopsy diagnosis, we come to know what is the pathology. And in pathology also, there are many types. Would you like to highlight anything, Dr.
Yeah, as you rightly told, PET-CT is very important for us. That will tell most of the time what type of tumor it is. It is like comparing the black and white TV, what we used to see, and now we have got HD 4K TVs. Similarly, PET-CT scan will tell the biology of the tumor, the stage of the tumor, and also to some extent the aggressiveness of the tumor. Now, coming to lung cancer, broadly we can classify as small cell and non-small cell. So non-small cell is more common compared to small cell. Non-small cell we have squamous and adeno. Squamous and adenocarcinomas are very common. Nowadays, because of smoking, as we have discussed before, we are seeing more and more incidents of non-small cell lung cancer. Small cell is little bit less compared to non-small cell.
Yeah. So it's very important to know the pathology, because the small cell variant is very aggressive.
Correct.
And the treatment is totally different, whereas the non-small cell has again got many types, and we have now various extra diagnosis, the genetic test to be done, some genetic mutations for which oral tablets are available, injections are available along with the chemotherapy. So a lot of options are available and a lot of tests need to be done. Now, after knowing all this, when can I undergo surgery? This is a common question. Like some patients ask, why not surgery for me? Why surgery was given for that patient? Why surgery is given not for this patient, or not, why it is not for me? So what is the exact role of surgery in lung cancer? Dr. Anil.
See, surgery plays a very vital role in early stage lung cancer. So suppose I have a patient who has stage 1 or stage 2 lung cancer. These are the patients where there is a clear-cut role for surgery. Normally, the other modalities are not deemed to have the same cure rates as surgery. So there is a what is the type of surgery we do? So we have to select the correct patient when we are doing so age is a very important factor. Now, when we are removing a part of the lung capacity comes down. So one of the critical questions for us is that, will the patient tolerate some part of removal of the lung? For this, we do what is known as a pulmonary function test. So we assess what is the possible outcome, how much is the patient's functional, coming down after surgery. The surgery which is typically considered standard for lung cancer is a lobectomy, where one part of the lobe is removed. So certain times, depending on the location, we may have to do more than a lobectomy. Sometimes we may have to go for a full lung removal, provided the patient tolerates it. Each removal of the lobe will bring down the function of the lung, say by 10-20%, depending on which lobe it is. So what is the expected outcome? After removal, will this patient become oxygen dependent? Will he be able to lead a normal life? These are the questions we have to ask ourselves, and there are various ways of assessing it. Apart from the lobectomy, we always stage the mediastinum. We remove some lymph nodes from the mediastinum to know the correct stage of the disease. Surgery traditionally used to be done by a long incision put on the chest. This used to cause a lot of pain to the patient. Nowadays, all this surgery is quite easily done by minimally invasive method, which is by a procedure known as VATS, video assisted thoracoscopic surgery, where under a video guidance holding a camera, the surgery is done through a much smaller incision. And the latest one is robotic surgery, which is much more of an advancement, where instead of rigid instruments, use the robotic arm, making the surgery more easy. When it comes to stage 3, there is a role for surgery, not as well defined as stage 1 and 2. But if it is operable, we definitely prefer to remove this one for better outcomes. Stage 4, there is very limited role for surgery, and we usually don't offer surgery in these conditions.
Just to add to what Dr. Anil Kamath mentioned, stage 3 is a little, there is always a dilemma and there's a gray zone. Again, stage 3A, nowadays there's a concept of neoadjuvant chemotherapy or immunotherapy, where we give chemotherapy with or without immunotherapy, depending on there are certain situations. For example, if there is no mutation, EGFR and ALK, which are genetic mutations, immunotherapy acts well. And when combined with chemotherapy, the response rates are very good. We give around 3 months of chemotherapy with or without immunotherapy. And then we send it back to the surgeon. And sometimes there are excellent responses and the surgeon is able to carry out the surgery. That way we have been able to give out good outcomes in stage 3.
Yeah, like other cancers, the role of neoadjuvant therapy. Neoadjuvant therapy means something which is given before the main treatment. Main treatment for most of the cancers is surgery. So any treatment which is given before surgery becomes a neoadjuvant. So there is a good role and good data about chemotherapy and immunotherapy. So I wanted you to actually enlighten us about what are the why chemotherapy, I mean, is it very dangerous, or these are the common myths? Chemotherapy means I will die, I will have a lot of side effects, I don't want chemotherapy, and these are some common questions which are haunting people's minds. So can you just enlighten us that burst this myth of chemotherapy? Chemotherapy is safe, and let's hear from Dr. Vishwanath.
Yeah, like you mentioned, Dr. Poonam, you nailed it. There are so much of myths associated with this chemotherapy. First thing they come and ask is, do I get pain? Do I get life-threatening issues with chemotherapy? The fact of the matter is that chemotherapy, yes, it is. It's also called cytotoxic chemotherapy. Apart from killing the cancer cells, yes, it does damage a few of the normal cells, but it is only manifested in terms of hair loss and low white count and platelet count, and maybe very rarely lung or cardiac issues, but most of them are manageable without any major life-threatening issues. And what good it does to the to kill the tumor cells is something which is forgotten by patients. And long story short, chemotherapy, there are a lot of myths which we are trying to dispel, and overall I think chemotherapy is something which has to be used by medical oncologists, which provides very good results, and the side effects are manageable.
So yes, we need to burst this myth of chemotherapy. Chemotherapy is taken as such a haunted word, and people are so scared about the word chemo, and they say that no, I don't want chemo, it is so painful. And thank you, Dr. Vishwanath, for bursting that myth. Let us make very clear to our audience, chemotherapy is painless. Point number one. Pain is not related to chemotherapy. Okay, pain is not at all related to the injection chemotherapy. It's just like any other medicine which is diluted and given to the patient. Yes, chemotherapy is a little stronger medicine because it needs to fight the cancer cells. But it is going to make them better, and that is what, if they understand completely, the side effects will automatically start to reduce. And there are a lot of chemotherapies in which there is no hair loss. What do you do? Just enlighten about those drugs. There are so many drugs which are safe.
Yeah. Like you said, Dr. Poonam, not every chemotherapy causes hair loss.
Yes.
So there are certain drugs, especially even concerning lung cancer. We talk about pemetrexed, which is one of the commonly used drugs. Even platinums, they don't cause much of hair loss. Nab-paclitaxel, albumin bound. So newer preparations these days, and the way we deliver chemo. And in fact, we have a surgical oncologist here. We put a chemo port, which is a device. That way we don't have to keep pricking the patient. So many things have changed. Better delivery, better satisfaction, and better quality of life for patients.
The nausea, vomiting, diarrhea, which used to be a concern several years back, is hardly there now. Actually, very few percentage of patients are getting this nausea, vomiting. There are excellent drugs which have come in the market, which have reduced this side effect a lot. So the point of this podcast is also to bring about this awareness and empower you all that safer treatment options are available, and treatments are not painful. There is no treatment being given with the pain. There are no treatments with pain. So even if surgery is done under anesthesia. Chemo is done, there is absolutely no pain. Radiation, we'll come to this. Now radiation also, there is absolutely no pain. And now I come to Dr. Vinay, because in Kannada they say, current kodtare. Namge current therapy le tumba baya. So what is this current treatment? Can you just enlighten about your radiation therapy?
Yeah, in Kannada, they routinely call current. It's not a correct word. I agree with you, Dr. Poonam, but people call that we have to take it, whatever that. So now that is actually an X-ray. Initially, you might have observed that I told X-ray is a cause for lung cancer. But the treatment also is that. As we tell in Kannada, mullannu mullin tegibeku. So it is a type of cancer which has to be treated. And it has to be treated with the high energy X-rays. So we use high energy X-rays to target the tumor in the lung. Now, lung cancer is totally different compared to head and neck cancer or breast cancer. What happens? As you know, the chest wall moves continuously. The tumor also moves continuously. But the movement of the chest wall, lungs, and the tumor in the lung is not symmetric, is not same, is different. But still, we have to target it. And there lies the challenge. How are we able to do it? One, we have a very good imaging facility. We need 4D CT scan in which we can track the lung tumor as we breathe. As the patient is lying down on a radiation machine, we can track the lung tumor. How do you do that? Either we can put a gold marker next to the tumor, or we can keep some surrogate marker on the body and track it. What is the use? So as the tumor moves, we will hit it. It's like a missile, hitting the target. Like that, we do it, and we treat that lung. So as Dr. Anil told, the initial stages of treatment is surgery, no doubt. But unfortunately, in India, as of today, we rarely see early stages. Don't you agree?
Yes.
So generally what we see, Dr. Vishwanath just not told about 3A, 3B, 3C. It's a locally advanced cancer, meaning from the lung it has spread to lymph node. So what do? We have to give radiation. After chemo or with the immuno. Or immuno we can add later. There are different types of treatment. But what do? We treat the lung tumor with little bit extra margin and the lymph node areas. Like this, what we are doing, we are treating the entire area. The idea is to combine the principle of surgery, treating the lung tumor and the lymph node, and give little extra dose. So what has happened now, recently if you ask, the main thing what has happened for our patients is, we have been treating radiation for lung cancer for 6 weeks. Now we only need 4 weeks. We are able to give higher dose. in lesser period of time, more comfort, less side effects. What else you want? That is the biggest thing I can tell for patients for reduction and duration. So we have reduced the side effects, we have reduced the duration of treatment. Coming to the other advantages, if you want me to continue,
Yes.
like we have the treatment machine called Proton in Apollo. That Proton is even more better compared to normal radiation, because in that much less dose goes to the heart or to rest of the lung. So there we have got a better quality of life. Coming to early stage, which we rarely see in India, but if there is an early cancer, lung cancer, if the patient is not able to undergo surgery because of the medical reasons or anesthesia complication, what do? We can do what is known as cyberknife radiosurgery. That's an excellent tool. As I told, we can put a marker next to the tumor, track it and target it. It may not be as good as surgery, but definitely comes close to surgery for early lung cancers.
So unlike the name cyber knife, there is no knife.
Yes, we use the principle of knife, but we don't use the knife.
Yeah.
We dissolve the tumor, or you can tell we make the tumor disappear.
With radiation.
With radiation. Of only 3 to 5 sessions, patient will come on OPD basis, take treatment, go home.
That's excellent. So nice to hear, no? Like we are delivering the specialized treatment, minimizing the side effects, minimizing the harm to the normal nearby organs by giving the precision oncology, and that's what Apollo promises, Apollo Cancer Center. So now let's see what is targeted therapy. Targeted therapy, we in the childhood we have seen the dart game and we are just targeting that. So it is something like that. So there are various targets available. And wonderful drugs are available, because of which this overall survival has dramatically improved even in stage 4, and stage 4s are not bad. That is what is the message. So Dr. Vishwanath, do you want to enlighten about the role of targeted therapy in lung cancer?
Yeah, like you said, Dr. Poonam, previously lung cancer was, especially stage 4, had a very poor survival. But these days we've been able to prolong their life significantly. Not only that, with also good quality of life. So there are certain mutations which can occur in patients with lung cancer, and this is especially there is a very common mutation called EGFR, and then there are other mutations, rarer mutations called ALK and ROS1. But talking about EGFR, which is the most common mutation, it usually occurs in non-smokers and especially in females. And it can go to the extent of around 70 to 80% in females non-smokers, and in smokers it is much lesser. But a patient who has got this mutation, they respond very well to oral pills which go and specifically target that particular mutation, and hence it's also called as magic bullet or targeted therapy. And these patients respond so well. Even those with brain metastasis, we have seen that they respond extremely well. And they also live long, and in fact now it is they say that stage 4 lung cancer with this targeted therapy and all, it's slowly becoming the new diabetes and hypertension, where they're taking pills and they're living longer with good quality of life. So that is how much we have kind of there's so much of advancements in lung cancer. And those who do not have the mutation also, it doesn't mean that they have no therapy. There is very good immunotherapy and chemotherapy, which again gives good survival and quality of life.
Yeah, I remember Dr. Vishwanath telling to our patients, don't worry, it's like a diabetic pill. You take tablet and you'll be okay.
Yeah. So people, more and more people, more and more patient population is living with cancer. Let's not forget when HIV came, AIDS came, it was such a big thing. It was such a big thing. I myself have worked in NACO center in Mumbai, and I know it was such a big myth and social taboo. But now people are living with diabetes, and it's an entity. It's an acronym.
Yeah.
People living with AIDS and HIV. It's an acronym, and people are living. They're taking their tablets. They're going to their offices. They're doing their work, and cancer is becoming exactly same. People living with cancer. It's an acronym. People are living with cancer, meaning they are working in their offices, they are doing their housework, they are managing their children, they are managing their spouse, they are managing their whole family, they are doing everything. In fact, some of our patients have started new business, new hobbies. So cancer doesn't stop life. That's a message. And Dr. Anil, I would like to ask you one more question. See, we say that in stage 4 there is no role of surgery. But suppose we come across some certain scenarios where all stage 4s are not same. The tumor burden is not same for all stage 4. All stage 4s are not bad. So if there is only 1 or 2 small lesions which are making it technically stage 4, what is your take for surgical approach? Because that might give a survival advantage to the patient and also quality of life and symptom relief.
The standard teaching is no role for surgery in stage 4, but in a fit patient with a very limited number of metastases, we might make an exception. So there are certain cases, say the metastasis has totally disappeared with chemotherapy and patient is young and able to tolerate the surgery. We can go sometimes out of the regular path and do offer them. And we have seen that some of the patients do extremely well. And with more and more new drugs coming in, we know that if we take care of the primary, the metastasis can be taken care of this thing. So there is some way, some role that we can go against the regular treaded path of no surgery to offering surgery in at least some of these patients where the behavior of the tumor has been good. We have offered surgery for patients with solitary brain metastasis, where the brain metastasis has disappeared after surgery, and the patient was coming to us for follow-up even after 2 or 3 years. So we do make some exceptions.
Yes. Exceptions, I think, are important because every patient of cancer and every patient in a particular stage is also not same. There are so many variants available, and that's why we do multidisciplinary tumor board, visit all the specialities from all the
also,
radiation.
Dr. Poonam, one more thing.
Yeah.
Dr. Vishwanath, I think he wanted to continue on immunotherapy.
Yes.
So what is immunotherapy? There are people a lot of questions.
Yes.
You know, they every day.
Immunotherapy, yeah, correct.
Present word. So
immunotherapy, newer modality of treatment.
What is it?
Let's hear from Dr. Vishwanath, because immunotherapy has come up in a big way. Earlier it was so costly, but now the patient assistance programs have made it affordable and reachable. So it's very much an option now. Dr. Vishwanath, what's your take on immunotherapy?
So years and years of work by a Japanese scientist, Honjo, and a scientist from MD Anderson Cancer Center, Dr. James Allison. That's how they came up with this molecule called immunotherapy, which specifically goes and modulates the body's immune system to kill cancer cells. So we were talking about those who have mutations, but what about those who do not have mutations? Those who do not have mutations, this immunotherapy works very well. Of course, it takes time to kick in, so we add some chemotherapy as well. And once it kicks in, we see patients living longer. In fact, we have a few patients who have also crossed 3 to 4 years of immunotherapy in advanced lung cancer, and they're doing well. And they just come once in 3 weeks or 3 weeks to take this infusion, which is on a daycare procedure basis. And this is a major advancement in the field of lung cancer. Not only lung cancer, now it's becoming a blanket treatment in several solid cancers. So immunotherapy is one of those drugs which have changed the, even I would say, the treatment paradigm in most cancers, including lung cancer.
So many treatment options are available, whether it's a medical, chemo, targeted therapy, immunotherapy, the surgical, so many options, radiation therapy. So we have spoken a lot about treatment. Now let's talk about, can we really prevent it? What's your take, Dr. Vinay? Can we really prevent lung cancer?
I don't know the answer. Maybe yes, maybe no.
So this question is for all of us.
Yes, because the reason what we know, we discussed before. If you are able to avoid and prevent it, yes, we can. But not all reason we can avoid, like genetic or the environmental. We cannot leave everything from here and go and sit in the middle of the forest. But still we may get lung cancer, we don't know. But routine things, yes. Maybe in future AI will help us. We will be able to see a CT scan in the lung and tell us that we may develop lung cancer or no in future. Maybe that possibility is there, I don't know. So what do you think, Dr.
What do you think?
Can we prevent it totally or not? I don't know.
The existing overall lifestyle what we have, I think it is difficult to prevent, but yes, early diagnosis can be done. That is by screening.
Yes.
So now we have the US task force and we have several guidelines which have come up for screening lung cancer, screening for lung cancer. So we use what is called as a low dose CT scan, which the radiation due to that low dose CT scan is very minimal. And this is restricted only to the high risk population, those who are chronic smokers over the age of 50-55 years and who've been smoking at least one pack a day for the last 20 to 30 years. They are considered as high risk. Only in those situations we are able to do this low dose CT scan. And like Dr. Anil Kamath mentioned, during COVID, patients used to come with CT and we used to see some early stage lung cancers which we were not seeing very often.
Yes.
So this low dose CT scan goes a long way in detecting early stage lung cancer. And then of course we have our good surgical colleague who can just go in and operate and give very good results for our patients.
What's your take on, can we really prevent cancer?
Prevention, sure shot prevention, not possible, because there is no single modality which you can tell you don't do this, you will not get. Risk reduction, not smoking, this one, healthy lifestyle, preventing occupational exposure, very much possible. Early detection, very much possible, but 100% prevention by following anything simple, that is not possible, because cancer is not as simple as that.
But I think we should not forget in educating all our viewers that abstaining from smoking is the single most important thing, and to always be a never smoker.
The whole idea of this podcast is to answer this question, can we prevent cancer? So the answer is not a clear-cut yes or no. It's not 100% preventable, but yes, that does not give you a that okay, healthy lifestyle se kuch nahi hota. It's not like that. Healthy lifestyle everybody has to follow, but that doesn't give you 100% assurance that you are not going to get lung cancer. So whether cancer can be prevented, the answer is nobody knows exactly whether it can be prevented. No, 100% it cannot be prevented, but healthy lifestyle can at least reduce the risk of getting the cancer. And the best mantra, I think we can conclude that early detection is the best prevention. And that means that annual health checkups are very, very important. So, and early detection is very important because there are no signs and symptoms. So if you go for annual health checkup, that's the best way to find out whether you have or you don't have. And it's only not about the cancer per se, but your overall health is also important. Now we are coming to concluding the podcast. Let's ask some common myths. What are the common myths in lung cancer? Now, people say that only males can get lung cancer. Females don't get lung cancer. What do you think, Dr. Vinay?
Yeah, both males and females are equally affected. Nowadays, we see more and more young females smoking. All the more it will add to the burden.
So age also is no more old age.
Yes, no. Yeah. And we cannot tell that males, generally yes, males are a little bit more because of a smoking habit only mainly. Otherwise, I think no much difference between male and female. Unlike other cancer, like uterine cancer or prostate, is not like that. Yes.
And other question to you, Dr. Vishwanath. Smokers say that I was smoking 10 years back. I have left smoking 10 years back. So does that help or not?
So I think as oncologists, we all know that the risk does not come down to zero. So of course, if you are a smoker, stop smoking as soon as possible. Your risk reduces, but it does not come down to zero. So there is always a risk once you smoke, and even if you have abstained for a variable period of time, the risk remains, but it comes down over a period of time. Long story short, stop smoking. The idea is never smoke, but if you are a smoker, please stop as soon as possible.
Yes, because smoking is not only related to cancer, not only lung cancer, but several other cancers. But it is also harmful for other, like your cardiac, heart health. It's not good for your heart health, for kidney, for your overall health. It's not good. So it's not only about cancer.
Because smoking doesn't come in only one; it's a package.
Yes.
Next, they will add alcohol.
Yes.
And then you will have all junk food. So
yes.
it will go.
It's a package. So let's get rid of that package and add a healthy lifestyle package. Dr. Anil, sir, I would like to understand that, okay, smoking, we are telling that smoking is the main causation factor in lung cancer. So why do you think, can you just tell our viewers that why this smoke is really dangerous? Like, why we should be away from this smoke? What at the genetic level or at the cellular level, how it damages our cells?
Yeah, the main thing is the cigarette, it contains this nicotine. Along with nicotine, it contains a number of other carcinogens also. And when you inhale, you're inhaling these carcinogens. These carcinogens affect the cell cycle. There is a particular way in which the cells will divide and multiply. So what the carcinogen does is that the checks and balances which are there within the cell cycle, there are ways in which the cells after multiplication are supposed to kill themselves. It is called apoptosis. This does not happen in a proper manner. The carcinogens affect each and every aspect of the cell cycles where these checks and balances are there, and that leads to this thing. By stopping smoking, what changes which have happened, you may not be able to reverse it fully, but you can prevent further changes from happening. So that's what I think when we discussed previously, sometimes even after quitting, they may still get lung cancer. And along with smoking, if there are other there is some people who are genetically susceptible to getting cancer. When these factors come together, or more than one risk factors come together, the chances go up quite significantly.
How important is genetics in lung cancer, Dr. Vishwanath?
Yeah, like Dr. Kamath said, genetics does play a role. And as we know, these mutations or genetic defects, there are some mutations which are called passenger mutations. There are others which are called as driver mutations. So passenger mutations usually remain dormant, but a driver mutation is the one, along with this genetics and other exposures like tobacco or other environmental pollutants, it can drive the formation of lung cancer or any other cancer. So yes, genetics is important, but may not be, it makes an individual susceptible, and with the addition of other inciting factors, yes, it does contribute to the formation of lung cancer.
But the role of genetics, only 10 to 15%.
Yeah, and it is not as common as say any other cancer. Say we are talking about breast cancer or ovarian cancer. It's not as common as.
So I think more than the genetics, the epigenetics has a lot of role. Epigenetics is nothing but the environmental, what is the environment given to the genes. So what is our external environment? What is our lifestyle? So let's close this podcast by talking about what can we do to prevent lung cancer. So what are the healthy lifestyles? I think all of you know, whoever is seeing this podcast, all of you know. So what are the healthy lifestyle tips that we can give to our viewers today? What they can really do to prevent cancer, lung cancer specifically?
Yeah, so many. So one of them, what I can tell is, you don't take undue stress.
Okay, very good. De-stress.
What do you think?
De-stress.
De-stress.
Yes. Then
relax.
What about you, Dr. Vishwanath? Add on some lifestyle tips.
So today we are talking more about lung cancer. So no smoking. So that way you will help yourself and also help your family members from becoming passive smokers.
Yes.
And of course, if your work involves a lot of environmental pollution, or like Dr. Vinay said, asbestosis and silicosis, where there is exposure to chemicals, I would say use masks like N95, which can also go a long way in reducing the exposure to such pollutants. And these days we are seeing, we talk about our cities like Delhi and Bangalore. All the urban cities are extremely polluted. So I don't know what do we do about that? Our policy makers, if they're listening to it, should do something about it. And of course, wearing masks like N95 could help. But these are the few thoughts which I had for lung cancer.
Not specifically about lung cancer, but obesity, yes. Very understated cause of cancer in general, associated with the many cancers like endometrial cancer, breast cancer, fatty liver, which can lead on to this thing. So many times it is not emphasized enough that obesity itself can be a risk factor for many cancers. So that is something we need to be aware. Regular exercise, dietary modification, these are essential to prevent cancer.
Yes, obesity, if we start, then it will become another podcast.
Yes.
What do you say?
Yes.
Obesity is a platter invitation for all lifestyle diseases, including cancer. So obesity, why obesity? Because we all know that extra fat in our body is a storehouse of all the harmful chemicals. All the harmful chemicals are released from that extra fat in the body, which is causing all lifestyle diseases, including cancer. So coming to a healthy BMI, including exercise in any form, all these are the simple lifestyle tips that you can take from us, and our viewers know all these tips. I mean, our viewers, everybody knows these days how to be
The only
healthy
problem
and
is they have
fit.
to follow it.
Yeah, so the
They
problem
know
is
everything in
the problem
YouTube.
is never about knowing,
Yes,
because
yes.
we all know it. It's all about
Yeah,
doing.
yes.
So motivate yourself every day to convert your knowing to doing. And these healthy lifestyle tips will go a long way to prevent not only cancer but also all the other lifestyle diseases, and to give you a meaningful, happy, healthy, holistic life. So thanks a lot. Thanks a lot.
Thank you, Dr. Poonam. Thank you.